Where do you see the future of the evolution of these drugs?
I think this is just the beginning.
Elon calls himself the Ozempic Santa. Oprah has tried Mounjaro too. Should you? India's top doctor breaks down the Mounjaro evolution, the risks, the results, and the reality behind this hype.
If you're a woman over 50, should you be going on these drugs? And is there a different impact on women than on men? Is there a different impact on menopausal women than women who still have periods?
I think that's a great question. And for me, that's a concern.
Dr. Mithal, is the weight loss revolution, as your book talks about, real, or is it a passing phase?
I think the weight loss revolution is definitely real. I don't think before this we had any tools to help us lose more than 15% of our body weight. And that's happened for the first time a few years ago. So I think these medications, the drugs are here to stay. What we had was, in terms of weight loss revolution for those who are severely obese, was bariatric surgery. And then we had lifestyle, which we all know very well about, but there was a huge void in between. And that has been filled up by these medications.
One of the interesting things you say in your book, and that has helped a lot of people re-understand obesity, is that obesity is a brain disease. And, Oprah Winfrey called this food noise.
Yes.
She said that, these drugs quietened the food noise in her head.
Yes.
And the food noise, quite simply, is that people genuinely have food cravings. I count myself as one of those people. There are some people who eat for every mood, boredom, anxiety, nervousness, joy, so many different moods. Talk a little bit about this understanding of obesity as a brain disease, as you write, and how these GLP drugs actually counter that.
So basically, when we think of obesity traditionally, we think this person just eats too much. That's how we look at it.
Intermittent fasting kar lo, sab theek ho jayega.
And people keep doing this and they lose some weight and it keeps coming back on. But the important part we have to understand is that with every successive effort, the loss becomes less. So for the same effort, after 3 or 4 tries, you get no weight loss.
You mean traditional ways of weight loss?
Traditional ways of doing it. So that's why now the thing is that there is obviously something that drives some people to eat more and retain more. Now, if you have in a family, you may have 2 people, living together, following the same diet, following the same exercise schedule. One person may be putting on weight with that, some may be losing weight with that. So there is a huge variation. Now, what is it that really determines this? So there are 2 factors. Number one is something that drives some people to eat more without even realizing it. And second is some people have a slightly different metabolism. Now, this eating more thing, which is genuine, because I see it all the time in my patients, they're genuinely trying. But there is what you call food noise in the head, and we just traditionally put it down to lack of discipline. Doesn't try, which is also there. So one can't take away that factor. But the fact is sometimes our brains are wired in a way that we tend to just crave food all the time, crave sweets all the time. And these drugs, the GLP-1 drugs, like...
What does GLP stand for?
So they actually act on the brain at that point.
So let's first, what is GLP?
So GLP is glucagon-like peptide. Now,
Which is what?
A gut hormone.
Okay.
So when we eat, it's secreted from our gut. There's GLP-1, there's
So the
GIP.
body naturally secretes GLP?
Yes.
Okay.
It's a natural substance in our body. Now this GLP, why does the body need GLP? It does several things, but 2 main things. One is it stimulates the pancreas to produce insulin and suppress another hormone called glucagon. That's not so crucial, but it stimulates the pancreas to produce insulin. That's how we sort of metabolize our food.
Yeah.
But it also goes to the brain and tells us to stop eating.
And why does it do that?
Because otherwise you'll keep going eating. There's no regulation.
As in, it's sending, therefore, a message to the brain.
Yes, enough.
So when I hear this, and I'm going to ask an unintelligent question here. Somebody like me is very concerned with drugs that are interfering in some way with my mind, right? Now, I know that this is an ignorant thing to say because even when I take a painkiller, it is doing precisely that. It is quietening some part of my brain that is, reacting to pain. But this idea that something is altering something in your brain, it's a chemical intervention, this concern, this fear, can you address that?
So yes, there is no doubt that there is a concern about that. Anything that acts on the brain, you don't know what else it might be doing.
Correct.
But going by the fact that you're mimicking a normal body hormone.
Right.
You're just enhancing the action of a normal body hormone, which is doing its job. Now, unfortunately, that hormone lasts only 2-3 minutes in the blood. So it comes out and
when
goes,
it's naturally
comes out and
secreted.
Goes. Yes. Now, when we use these molecules, number one, they last days or weeks. And number two, they are more potent in some ways. So they're acting through a receptor or through a path which the body is already utilizing. So one expects that there would not be any major brain-related.
So in layperson's terms, it's quietening your need for food.
Yes, it is. It is. It does both. It actually, you feel full sooner. Your satiety center is activated. And your appetite itself goes down. So both phenomena happen.
So traditionally, bariatric surgeries, before these drugs existed, would have done something similar because it would have reduced the space. Am I saying this right? Basically, making your stomach smaller and making you want less food.
So there's a slight difference.
Okay.
Bariatric surgery doesn't primarily have a brain action. Although there are GLP changes even after bariatric surgery. That also helps. But primarily, it just reduces the food absorption or creates a path by which we just don't absorb food. Or we can't eat that, physically can't eat that much food because stomach is smaller or it doesn't absorb. That is the principle of bariatric surgery. But also it does something to GLP-1, not the main action.
So over what period of time would somebody who's taking a GLP drug begin to see changes in weight loss?
It's hugely variable, Barkha. So typically we tell a patient to be patient for 3 months. Okay. But there are some who lose weight in the first month, 3, 4, 5 kilograms. There are some who start losing weight after 3 months. So there is a lot of variation. But you would say that by 3 months, if you're not seeing a result, something's not okay. We need
and
to
what would that be? It doesn't work on everyone? What's your experience?
So it doesn't work on everyone. Roughly 10% of people don't respond well, which means they respond with a weight loss of 3 kilograms or something, which is called a poor responder. The newer developments in this will keep reducing this proportion to less than maybe 10 to 5 to 3 to 2, but there's never any drug that works for everyone. So there will be 10% people who we discussed this point at the beginning itself, because setting expectation is very important. So there will be 10% people who don't respond that well as we would like them to. So we classify them as non-responders.
What is the difference between all the drugs available in this category? How do they act differently? What is their difference? Is it a difference only of brand name, or are there fundamental differences between, let's say, an Ozempic and a Mounjaro?
Yes. So just to sort of preface that, GLP-1 drugs we have been using for treating diabetes since 2005.
So these drugs have existed since 2005?
Not these two, but their predecessors.
Okay.
So we have a whole cupboard of GLP-1 drugs.
Okay.
First one was something called exenatide, then liraglutide, dulaglutide, all those with them. They were all very good anti-diabetes agents. They didn't become so popular because they're injectable. Now, what is...
ये भी तो injectables है.
I know, but the thing is that for weight, people do much more than they do for diabetes.
Imagine the irony.
But that's what it is.
Yeah.
So the key thing that these two molecules have done, the ones you're talking about, is they've crossed that 15-20% threshold. That is huge.
Explain that.
Which means that if someone is 100 kilograms, one can, and doesn't have any other there are a lot of subtleties and nuances there, but it's straight weight reduction. Then you actually can expect to lose 15 to 20 kilograms.
In what time period?
Maybe 6 months.
Wow.
Yeah. Maybe a year, but definitely by a year. Most people would do that.
And those who don't respond, do we know why they don't respond before we come to the success stories?
That's the research. That's the current research. Who are the non-responders? And we are facing that too. We are analyzing our own data and worldwide people, because once a drug is successful, that becomes the next point. Who are the guys who are not responding? So one group, for example, is very important to understand that people with diabetes respond little less than those without diabetes. So those with diabetes, they lose 20 kilograms, let's say. Then a person with diabetes maybe will lose 15.
Now, these drugs, as you said, were created as diabetes drugs.
Yes.
And the weight loss dimension of them was discovered, I guess, quite by accident or as a positive side effect or so on. However, now they're primarily weight loss drugs and not drugs to treat diabetes. I think the way to think of it, though, is that this is not a cosmetic intervention, but a health intervention, because so many other diseases are related to being obese. Arthritis, autoimmune diseases, and so on. So how do we understand these drugs? One way of understanding them is these are earlier, when they first came, they were considered the drugs of the elite, the super rich. Now they're not now they're not seen as that, right? How do you look at these drugs? Do you look at them as a way for people who want to look better? Or do you actually look at them as this is a really serious, dramatic health intervention?
So I think the latter is definitely true. I think these drugs are game changers for our health. They are not for everybody and they may have side effects. We'll talk about that.
Yeah.
But the truth is that doctors are not looking at these drugs as cosmetic measures. We are looking clearly at obesity is a condition or a disease. If we lose fat, along with other beneficial effects, diabetes will go away.
Yeah.
Blood pressure will come down.
Yeah.
Heart disease will come down. Kidney disease progression comes down. Fatty liver melts away. And then the arthritis and all those other things. So it's a huge medical advance, which is what I keep telling people. When you're looking at them purely as cosmetic drugs and then you're looking at side effects, a different story. We are looking at these drugs reducing, semaglutide, for example, 20% reduction in cardiac events for people with diabetes.
Can you take us through in detail how this drug acts? So, any of these drugs, there's not one.
Semaglutide is the prototype right now. That is a GLP-1 agonist. That is a drug that acts like GLP-1, acts on the pancreas to enhance secretion of insulin, suppresses the glucagon, acts on the brain to control our appetite and other things, acts on the movement of the gut. It slows down stomach movement. So all these things this drug does. Now, there are many other modes of action which are not understood.
Like
anti-inflammatory action, it seems, is more than just through the fat.
See, so you mean it's you mean that apart from containing weight or reducing weight, it is having an anti-inflammatory impact.
What recent studies
that could help other diseases triggered by inflammation.
Yes. That's exactly what current.
Like Alzheimer's?
So Alzheimer's much of these effects are linked to just fat. See,
Alzheimer's is linked to fat?
We look at like weight, external weight. But what happens is there's fat deposited inside our organs, around our organs. And that plays a big role. Like the liver, you all know fatty liver. That is fat inside the liver. So similarly, there are brain lipid alterations. Now, these drugs presumably act at that level. And therefore, Alzheimer's studies are fascinating. Even Parkinson's, not proven yet, both of these, but Alzheimer's is at a more advanced stage. And we do expect that something positive will come out, but we have to wait and see. So the action, and we'll find many other benefits, that's my guess. The key research questions, one you already asked, who are the responders, who are the non-responders? The second is, what actions are determined purely by reduction of adipose tissue, as we call fat inside, and what are independent of that? That is being worked out. And one of the things that's emerging in that is that the anti-inflammatory action may be not just linked to the reduction in fat.
And that's fascinating and fabulous. But let's come to the flip side, the side effects, right? One of the things that sounds scary, somebody like me who has a nervous stomach, travels a lot, is on the road a lot, has to work a lot, gets uncomfortable if my stomach is not feeling comfortable. Here's these stories of periods of nausea, gastric discomfort. How severe are these? Do we have enough research? Are they mild? Are they the kind that, you have a loose tummy, you take a Norflox, it becomes okay. You take a Perinom for your nausea, it becomes okay. Or is it something graver?
With full doses of these drugs, almost half the people get these effects. That's a very high percentage. So mild nausea is very common. It's rare not to have some nausea.
Okay.
But that's usually people handle it well. more severe nausea and even vomiting, and sometimes significant constipation. I've had patients very distressed by constipation, episodes of diarrhea. All these are known and they're not uncommon.
And why do they happen?
Because it's a gut hormone, basically. So it's acting on the gut.
And everybody is responding differently.
Yes, differently. I mean, imagine constipation and diarrhea, either can happen.
Yeah.
So they clearly have gut-related side effects. Now, that is the downside, of course. The day you have some molecules that don't have those effects, it'll be another huge jump. Nevertheless, most of these side effects can be managed by normal stuff.
Like?
Take an antiemetic, take a pantoprazole or something, for your acidity, take something, isabgol for constipation. Most of them can be managed like that.
And how long do these side effects last?
And the other important point is that they're mostly transient. So people who are able to hang in there for, few weeks, they usually do very well. Now, the problem is that these drugs are started in low doses and built up slowly. It's very important to start low and go slow. So because the drugs are started at a low dose,
and typically it's once a week, the
once
dosage?
a week injectable. So if you
self-inject or
self-inject. So every time you go up on the dose, again the side effects may flare up temporarily. But I've seen that by that time patients are pretty well used to handling them. It's the first few weeks that they really require help. I think, and I was saying this, it's quite amazing how much people will tolerate for the sake of weight loss. Whereas the doctor is looking at the HbA1c and the body adipose tissue and the decline in blood pressure and lipids, etc. Patients will tolerate these side effects for the sake of weight loss. I find that actually amusing in a way, because they will complain about the most minor side effects of any anti-diabetic or BP medicine.
Yeah.
But this, no, we'll manage. The moment I say, no, I'm going to stop it. No.
Is it because they see results? And with a lot of other things, you don't see the tangible results immediately.
It's a physical effect. It's a physical effect.
Yeah.
Absolutely.
But are these drugs lifelong?
Well, that's a good question.
Once you take one of these drugs, GLP drugs, to maintain that weight, are you going to be on one of these drugs for the rest of your life in the same way that many people are on blood pressure medicine or diabetes medicine or antacids or anything,
So,
I'm personally, for example, perennially on anti-asthma medicines, right? And I live in Delhi. I know that for the rest of my life, there are phases of the year when I'm going to have to be on a certain kind of drug to get. So is it like that?
So, okay. If you look at it in a very simplistic way, then if you look at obesity as a disease or a condition which requires treatment like diabetes, hypertension, whatever, asthma, you will require medication for life. Now, I don't think that's true for everybody.
Okay.
Now, for example, if I have a 50-year-old person with diabetes and obesity and I put him on these GLP-1 drugs, which I was doing earlier anyway, so they're going to stay. I don't think they're going to go away.
Why?
Because you're treating diabetes.
No, suppose you're not a diabetic.
Now, supposing it depends on your degree of obesity. Now, if you are one of those where obesity really is a serious condition, I would recommend just continue. Okay. But there are many who are trying to do this for borderline sort of indications. And I definitely would want many of them to slowly taper off the drug.
But does that mean a lifelong of nausea and discomfort, or you're saying that goes away, your body adjusts to the drug?
That goes away. That body adjusts. That goes away. It becomes weight maintenance after some time. That's all. You're not continuing to lose weight. You maintain your weight. The nausea and all is quite tolerable. Most people don't complain after some time. And yes, some people will require them lifelong. Those who have more significant abnormalities, more significant disease will require them lifelong. Those who are doing it for like a little bit of weight loss, although within the prescribed boundaries, but then probably they should be working very hard to try and go off these drugs, in a couple of years.
Now, these sound almost like miracle drugs, and you've said that so far, research shows that the main side effects for most part are nausea and gastric discomfort, either constipation or diarrhea. There have been some concerns, I don't know if backed up by evidence, of damage to the pancreas, pancreatitis as a possible side effect. Some concerns about impact on vision. I want you to talk a little bit about what the research tells us about.
Yes. So the pancreas part is interesting. In all these incretins, these GLP-1-like drugs, act through the pancreas. There has always been a concern that they may aggravate pancreatitis. Even the oral drugs like sitagliptin, vildagliptin, that all we use all the time for people with diabetes, could also potentially aggravate the risk of pancreatitis. It's exceedingly rare. The risk of pancreatitis in people with diabetes and with obesity is in any case quite high. So maybe they add a little bit there, but it's not a serious concern unless you have a history of pancreatitis, in which case you have to stay away from it.
And how do you know that?
Well, you would not miss pancreatitis. It's a big episode. So if someone has had that, then they would
it's
know.
not that you have it and you don't know that you have it.
That also happens, but that's really rare. That's really rare.
Okay.
So that is one. So pancreatitis, all it means is those who have history of pancreatitis, stay away from it. But that shouldn't be a reason for you to avoid the drug. The second is eye. Now, that's the most intriguing phenomenon with these drugs, which is really poorly understood. There are equal number of studies that show increase in risk of eye disease and no increase in risk of eye disease. There are some studies showing that you can actually reduce the progression of eye disease. So most of the studies are not what we call clinical trials. They are observational data.
So it's still anecdotal data?
So it's more than anecdotal, but it's not quite there yet. And the risk, if at all it happens, will be exceedingly low. So I'm hoping it doesn't happen. Large trials are ongoing. We expect the results by 2027. But as abundant caution, and some of my colleagues don't agree with that, I always get a detailed eye check for everyone where I prescribe.
Why don't your colleagues agree with this? It seems basic precaution.
But it's for a non-diabetic, it adds to the...
But what would the eye test be testing? I mean, for example... I wear glasses. I can't see at a distance.
There's the retina and optic nerve.
I see.
So you're not preventing anything. These things happen suddenly. But if someone has something underlying...
Who would you not give it to?
So if someone has some underlying retinal issue...
What issue?
So basically macular issue.
Okay.
Or older people, maybe there is age-related macular degeneration, not uncommon. If all that is happening, I would stay away till we know more. I may be wrong and they may have nothing. But I take that precaution.
Now, this is a gut hormone, as you explained. I want to ask a question specifically through the lens of gender. Women struggle with weight in a way that often men don't, point one. Point two, menopause brings its own issues with weight loss because your hormones are changing. HRT, hormone replacement therapy, is a divided subject in India. If you're a woman over 50, should you be going on these drugs? And is there a different impact on women than on men? Is there a different impact on menopausal women than women who still have periods?
So results in women are very encouraging.
Okay.
If at all, they seem to work little better in women than in men.
Finally, some drug that works better for women. Yeah.
And even for menopausal weight gain. They seem to work well.
Because that's the one weight gain that women really struggle. Like they suddenly wake up and they find our bodies have changed.
Bloated.
Why have our bodies changed? And you're the same person, but your body hasn't. The body is different. You're the same.
Yes. So they work well for that. And in fact, as I said, overall it seems the weight loss is a little greater in women than in men. So I think the gender details again will appear more and more in the data.
Do you see any concerns for women in particular, either menstruating women or menopausal women?
I think that's a great question. And for me, that's a concern. The concern is these young girls who have PCOS, 25-year-old, and they're planning a family and they're unable to conceive because of the weight. Okay. Now, so these drugs are used for these people, for such patients, and you put them on the medication, they lose weight, fantastic. But then when you plan pregnancy, you have to take it off. Okay, so you take it off. Now, in a condition like polycystic ovary, pregnancy doesn't happen immediately. It may happen, 6 months later. So that period then, they are without the drug and there is a tendency to put the weight back on, at least partially. Then you get pregnant, then you put more weight on, and then you're breastfeeding. So that whole cycle, when do we restart, where will it lead, is an unexplored area. So I always, I emphasize in everybody, but in younger patients, I really emphasize lifestyle because I think, at some point you have to be prepared to go off the drug. One way is I ask them to keep a food diary. Now, you try and eat the same when you're not on the medication, those kind of things. So I see that as a challenge, that how long will these girls take it?
And for older women?
It's okay.
If it's not as alarming.
Not a problem.
And it doesn't interfere with other hormones. Because menopause is also so many hormonal changes.
Yeah, but it doesn't. The only sort of concern
does it impact estrogen levels, which are already depleting?
No.
Nothing. No impact on that.
So older people, there's a both younger and older people, but especially in older people, there is a concern about muscle loss.
Right.
Now,
because when you lose fat, you also lose muscle.
So this concern is not a drug concern. This concern is a weight loss concern. So when you lose weight, you also lose some muscle. 20-30% of weight lost is muscle. Okay. So my concern is Indians in any case don't have good muscle mass. So in older people who are not really good with their protein intakes, not really good with their exercise, if they lose weight drastically through these measures, they will lose significant muscle, which will increase their chances of falling, breaking a bone, osteoporosis, all those things. So that is a
which is
concern
the sort of the opposite of what, you're taking this drug because obesity can cause those problems anyway.
Yes.
And then if you take the drug and you're not doing weight training or protein intake, then you're back to square one in health terms.
Absolutely. And I think that maybe not to square one, but significantly there can be an impact.
So do you think enough of your patients who are using these drugs understand that the drugs are not a substitute for every lifestyle choice?
So different people have different responses, this is my biggest struggle these days, is to explain to the person who's opting for these drugs, these things are important. Some of them take it as a really good step because they've been genuinely struggling with their weight and now they got a chance and they'll do everything to keep it off, right? But there are others who actually have said this to me कि अब जब दवाई से weight कम हो रहा है तो फिर अगर exercise ही करनी थी तो पहले ही कर लेते फिर. So that's not the right way. So I think it's a mix of people, but those who are serious about their weight and those who are using these drugs as something to bolster their efforts and giving them that kick, where they are doing very, very well.
Have you seen any research on impact on mood swings? And the reason I'm asking this is if something is sending a message to your brain, potentially there could be some impact there.
I think that's a great question. You're asking all the questions which are under research.
Yeah.
But yes, most people feel very good when they lose weight.
Yeah.
They feel so good. I mean,
it's like having serotonin.
Yes, it's like, every day I meet at least one or two people who tell me that my life has changed, doc. Everything is fantastic. I'm so positive in my job, at home, everything. Something I've been trying to do for years hasn't happened. So positive mood change. But there are some who do feel a little low. And there are those who have lived their life on food.
The joy of food.
The joy of food. And sometimes they wonder, why am I doing this? What's the point? Alcohol also, because some people can't have alcohol with this.
Does it combine all right with alcohol or it doesn't?
Some people get significant aversion.
Okay.
So they say, I can't have a drink. A good Delhiite will say, doctor, what's my life?
You've taken away my Patiala peg. Yeah.
So there are issues. But by and large, the direction is positive. However, those who are on complex psychotic medication, and there are patients like that because obesity and depression go hand in hand. Those are on 3 or 4 drugs, and then we tend to avoid these medications because we really don't know yet.
What is the difference in... Okay, how many drugs are available right now for this? Because we tend to use Ozempic and Mounjaro as the shorthands.
Yes.
I'm sure there are more.
Yes.
And what are the differences in them?
Yeah, I think so that's a very important point. At the moment, from this class, there are 2 drugs available worldwide.
Which are?
One is semaglutide, which is available as Ozempic or Wegovy.
Okay.
Right? Also an oral form as Ribelsus, but we'll leave that out. That's primarily anti-diabetic. So
doesn't have the same impact?
Well, they're trying higher doses and finding amazing impact. At the moment, availability, not to confuse people, that is for diabetes. These are for weight. So if you talk of Ozempic and Wegovy, in India, it's available as Wegovy.
Okay.
Not as Ozempic.
But it's the same as
exactly
Ozempic?
Exactly same company, regulatory, norms. And so that is one. That is a drug that acts through GLP-1 alone. So that I think that drug has maxed out what you can do with GLP-1.
That's semaglutide.
That's semaglutide. The other drug, which came shortly after that, it came to India before that, but worldwide was developed shortly after that, is tirzepatide, which is Mounjaro, or in the US, Zepbound. So Mounjaro
in the US is called?
Zepbound also.
Okay.
So Mounjaro and Zepbound, let's just talk of Wegovy, which is semaglutide, and Mounjaro, which is tirzepatide. So that has an additional action because it does GLP-1 agonism. It acts through the GLP-1 pathway, but it also acts through the GIP pathway,
which is
another gut hormone.
So there are two gut hormones?
Yeah, there are several. These are the two main ones.
Okay.
So GIP role is always been a bit, poorly understood, not so important in diabetes, all those things. So this is a molecule, a single molecule that acts through GLP-1 and GIP. So that is an amazing science. It's not two molecules, one molecule acting through two pathways. So that seems to have, in terms of weight loss, a slightly greater impact than semaglutide.
And does it have more side effects?
Seems to be a slight difference, but it's anecdotal.
Mostly
but it's
the
not,
same?
Mostly the same.
Is there a price point difference between the two?
In India at the moment, no. But I do expect that next year, and even today I read something, semaglutide, some forms of semaglutide will go off patent. So then I think
become like a generic?
at least 6 companies are ready with it. I also know that.
So the prices will go down.
So I think April next year or something.
Which means the prices will go down.
Yeah. So that is a double-edged sword, Barkha. Because as the prices go down, that's fantastic.
और सब ले रहे होंगे फिर.
सब ले रहे होंगे. और फिर regulation कैसे होगा? In small cities and with chemists, you can get any doctor to prescribe. That's a challenge. But access is most important.
So when these drugs first arrived, there was some talk or chatter about food lobbies, junk food lobbies, sort of very quietly lobbying against this because if food cravings go down, then it's a direct hit on bags of chips and bottles of Coke and so on. Do you see that happening? Do you see pushback from lobbies? Equally, people could argue that there are very strong sort of drug lobbies that will want these drugs to be cheaper, easily available. So how does a lay person navigate sort of the deep commercial interest that exists, both on those who want these drugs to come and those who want them to not come?
So that's the journalist in Barkha to the fore. So I really don't have an answer for that. I have a very simple one-line suggestion. Listen to a doctor you trust.
And do it under the supervision of a doctor?
Always do it under the supervision of a doctor. That's my biggest thing because people are wanting to do it, just with a phone call or not even asking their doctor.
Self-medicate.
Yeah. It's already happening. So that's a concern because, you haven't done your screening properly. You don't know and you just start the medication, then you land up with a side effect suddenly in the emergency, then the medication gets blamed.
Yeah.
So every drug is bad if it's used for the wrong patient.
So let's talk a little bit about the future. One is the alarming. So everything that is alarming is also great.
Yes.
Right? So one is that this is not going to be a drug of the rich and the elite. It is soon going to be widely affordable. Yes. That's great. Yes. The downside of that is people may start self-medicating without medical supervision. Yes. The really exciting news out of this is the unintended consequences on inflammation.
Yes.
The kind of inflammatory diseases that we don't fully understand, for which no other medication has worked. How much do we know about that right now?
I think that's the area where people are working. Longevity. Amazing initial studies coming out.
Really?
Longevity, yes.
Wow.
So the whole thing, so it's very possible that much of a chronic disease burden, aging, everything is determined to a significant extent by the visceral adipose tissue.
Because if you're reducing inflation and reducing fat, you're going to do better, basically, for yourself.
Yes.
And the future of these drugs, I think they'll probably act even more swift rather than the other way around. Like, where do you see the future of the evolution of these drugs?
I think this is just the beginning, Barkha. I think the future is very exciting. As a doctor, as a scientist, I find it a very interesting area because you have now a drug developed that acts on 3 pathways.
Which is the third?
Retatrutide, glucagon pathway.
So there is the 2 gut hormones and then also the third which drives the inflammation.
There's also a gut hormone, so 3 hormones you can say. And you GLP, GIP and glucagon and one molecule acting on 3 pathways, achieving 25% weight loss. But that's one part. That is just the weight loss. The other thing is you have more oral preparations coming in, making it easier for people.
Because a lot of people will still be scared of an injectable.
Yes. And once a month injections to make it even easier.
But that would be higher dose?
Well, we don't know yet, but yeah, it'll obviously be a higher dose, but different molecules, different preparations. So oral, once a month. Very interestingly, drugs that promote muscle gain. So you combine these with that, so the muscle loss problem can be obviated. I mean, that for me is a dream. Those kind of drugs. And these are in fairly advanced stages of development. So
and is there an age dimension to it? Does it work better on younger people, the drugs? Or, in your patients, do you see any difference in how it plays out on younger and older people?
So this is still anecdotal. But the fact is that those who have been really careless about their food and have done nothing, the younger group, where, they've just come for obesity, typical... multinational executive or a media house person, they all are putting on weight. So they respond amazingly well, because I think the problem is purely food intake.
But older
and
people?
Boom, and it just
older people?
Older people, it depends on the comorbidities. If they're taking insulin, if there are other drugs that raise weight, if they have other reasons, so then it becomes a little less predictable. So
and for women who are older, and I ask this because they're undergoing other hormonal changes.
No, but the response there is good.
It is?
Yeah. There's no...
So what about the Ozempic face?
Yeah, so...
Is it a real thing? Like we use it as shorthand for celebrities who are suddenly looking very gaunt, who are actually looking less attractive than they used to look, right? Yeah. Because they've suddenly got these sunken cheeks and gaddhas under their eyes and so on. So is there such a thing as an Ozempic face?
So you can call it an Ozempic face, Ozempic face, or Ozempic hand, Ozempic butt. People are using all those words. So whenever you lose your body fat quickly and the supporting tissue goes down, that's what happens. When people used to lose weight for any other condition earlier, they would still look gaunt, right?
Yeah.
It's the same thing. So it is not the drug that is causing it.
It's just the loss. It's just the loss of the fat. So what is the way to avoid it?
We just go slow. Again, monitoring. I'm certain people who are looking so gaunt and have so-called Ozempic face have not been following their...
or have taken very high doses straight away.
High doses, refuse to bring them down. Sometimes people get fixated on numbers. I want this BMI. I want this body weight. And they say, no, doc, I'm not going to reduce my dose. I need to hit, that is my target.
Yeah.
Because that is how I was in school or college or something. So, if you push yourself that much and your skin is already stretched because you've had that fat for some time, going too fast in that direction, that's when, otherwise there's no reason.
So let me end by asking you, as an endocrinologist, what excites you the most? What concerns you the most? And where do you see the future evolving?
I think these drugs are undoubtedly very exciting. As I was telling a friend, it's like a statin discovery. It's that big.
Wow.
Okay, I think they're going to change the way we look at human health. And the other exciting part is that this is just the beginning. There's lots more on the horizon. It opened up a channel which, scientists are attacking on all fronts. So that is the most exciting part.
And do you think the management of the side effects will also improve with time?
Yes, that's the goal.
Yeah.
That's the goal. Of course, my concern is unregulated use is a big concern at the moment. And later on, of course, I'm concerned that some rare side effect may not emerge after 10 years of use or something.
Yeah.
We can't do anything about that. That's true for any drug. But the fact is these drugs are being used by millions. So therefore, it becomes more important. See, the more normal a person who uses the drug, the more concerned you are about side effects. If you have a serious disease, some side effects you tolerate.
Yeah.
So that's the thing. So I'm hoping it will not happen. So unregulated use and long-term side effects, which hopefully will not emerge, hopefully because 20 years of GLP-1 hasn't shown us anything. So I'm hoping that they will not emerge. These are the concerns.
It is an absolutely inflection point in medicine. And I think that is the way to look at it, absolutely. As opposed to some sort of pill-popping fashion fad, which it must not become.
Yes.
And I think, Ambrish Mithal, your book, I urge everybody to pick up a copy of Dr. Ambrish Mithal's book. It really is a revolutionary moment in medicine. And the way, if indeed beyond weight loss, it also tackles inflammation, I think that would be a really big and giant breakthrough. Thank you so much.
Thank you, Barkha. Thank you for having me here.
Thank you.